small intestine is a remarkable and complex organ that is not only the principal site of nutrient digestion and absorption but also contains the body's largest reservoir of immunologically active and hormone-producing cells. Hence, it can be conceptualized as the largest organ of the immune and endocrine systems. 1. It achieves this diversity of action through unique, anatomical features, which provided with a massive surface area, the diversity of cell types, and a complex neural network to coordinate these functions. Despite the size and importance of the small intestine, diseases of this organ are relatively infrequent and can present diagnostic and therapeutic challenges. Despite introduction of novel imaging techniques such as capsule endoscopy and double balloon endoscopy, diagnostic tests lack sufficient ability to reliably assess the small bowel. Furthermore, few high-quality, controlled data on the efficacy of surgical therapies for small bowel diseases are available. Therefore, sound clinical judgment and a thorough understanding of anatomy, physiology, and pathophysiology remain essential to the care of patients with suspected small bowel disorders. Gross anatomy. The small intestine is a tubular structure that extends from the pylorus to the second. The estimated length varies depending on whether radiologic, surgical, or autopsy measurements are made. In the living, it is thought to measure 4 to 6 meters. 2. The small intestine consists of 3 segments lying in series: the duodenum, the jejunum, and the ileum. The duodenum, the most proximal segment, lies in the retroperitoneum immediately adjacent to the head and inferior border of the body of the pancreas. The duodenum is demarcated from the stomach by the pylorus and from the jejunum by the ligament of Treitz. The jejunum and ileum lie within the peritoneal cavity and are tethered to the key points. 4. Tumors and malignancies of the small bowel are rare and difficult to diagnose. 5. If following surgical resection less than 200 cm of small bowel remains, patients are at risk of developing short bowel syndrome. 1. The small intestine performs a diverse set of functions. 2. Small bowel obstruction is one of the most common surgical diagnoses. 3. Most cases of small bowel obstruction are due to adhesions from previous surgery and resolved with conservative management. Retroperitoneum by broad-based mesentery. No distinct anatomical landmark demarcates the jejunum from the ileum. The proximal 40% of the jejunal segment is arbitrarily defined as the jejunum and the distal 60% as the ileum. The ileum is demarcated from the second by the ileocecal valve. The small intestine contains internal mucosal folds known as pliques circulares or valvulae connivens that are visible upon gross inspection. These folds are also visible radiographically and help in the distinction between small intestine and colon, which does not contain them, on abdominal radiographs. These folds are more prominent in the proximal intestine than in the distal small intestine. Other features evident on gross inspection that are more characteristic of the proximal than distal small intestine include larger circumference, thicker wall, less fatty mesentery, and longer vasa recta fig. 28.1. Gross examination of the small intestinal mucosa also reveals aggregates of lymphoid follicles. Those follicles, located in the ileum, are the most prominent and are designated Peyer's patches. Most of the duodenum derives its arterial blood from branches of both the celiac and the superior mesenteric arteries. The distal duodenum, the jejunum, and the ileum derive their arterial blood from the superior mesenteric artery. Their venous drainage occurs via the superior mesenteric vein. Lymph drainage occurs through lymphatic vessels coursing parallel to corresponding arteries. This lymph drains through mesenteric lymph nodes to the cisterna chyli, then through the thoracic duct, and ultimately into the left subclavian vein. The parasympathetic and sympathetic innervation of the small intestine is derived from the vagus and splanchnic nerves, respectively. Histology. The wall of the small intestine consists of 4 distinct layers: mucosa, submucosa, muscularis propria, and serosa fig. 28.2. The mucosa is the innermost layer and it consists of 3 layers: epithelium, lamina propria, and muscularis mucosae. The epithelium is exposed to the intestinal lumen and is the surface through which absorption from and secretion into the lumen occurs. The lamina propria is located immediately external to the epithelium and consists of connective tissue in a heterogeneous population of cells. It is demarcated from the more external submucosa by the muscularis mucosae. The first recognizable precursor of the small intestine is the embryonic gut tube, formed from the endoderm during the 4th week of gestation. The gut tube is divided into foregut, midgut, and hindgut. Other than the duodenum, which is a foregut structure, the rest of the small intestine is derived from the midgut. The gut tube initially communicates with the yolk sac. However, the communication between these two structures narrows by the 6th week to form the vitelline duct. The yolk sac and vitelline duct usually undergo obliteration by the end of gestation. Incomplete obliteration of the vitelline duct results in the spectrum of defects associated with Meckel's diverticuli. Lamina propria, smooth muscle cells, blood vessels, central lymph, embryo splits. The portion of mesoderm that adheres to the endoderm forms the visceral peritoneum, while the portion that adheres to the ectoderm forms the parietal peritoneum. This mesodermal division results in the formation of a coelomic cavity that is the precursor of the peritoneal cavity. At approximately the 5th week of gestation, the bowel begins to lengthen to an extent greater than that which can be accommodated by the developing abdominal cavity, resulting in the extracoelomic herniation of the developing bowel. The bowel continues to lengthen during the subsequent weeks and is retracted back into the abdominal cavity during the 10th week of gestation. Subsequently, the duodenum becomes a retroperitoneal structure. Coincident with extrusion and retraction, the bowel undergoes a 270 degrees counterclockwise rotation relative to the posterior abdominal wall. This rotation accounts for the usual locations of the cecum in the right lower quadrant and the duodenal junction to the left of midline fig. 28.3. Celiac and superior mesenteric arteries and veins are derived from the vitelline vascular system, which in turn is derived from blood vessels formed within the splanchnopleurotic mesoderm during the 3rd week of gestation. Neurons found in the small intestine are derived from neural crest cells that begin to migrate away from the neural tube during the 3rd week of gestation. These neural crest cells enter the mesenchyme of the primitive foregut and subsequently migrate to the remainder of the bowel. During the 6th week of gestation, the lumen of the developing bowel becomes obliterated as bowel epithelial proliferation accelerates. Vacuoles form within the bowel substance during the subsequent weeks and coalesce to form the intestinal lumen by the 9th week of gestation. Errors in this recanalization may account for defects, such as intestinal webs and stenosis. Most intestinal atresias, however, are believed to be related to ischemic episodes occurring after organogenesis has been completed rather than to errors in recanalization. During the 9th week of gestation, the intestinal epithelium develops intestine-specific features such as crypt-villus architecture. Organogenesis is complete by approximately the 12th week of gestation. Figure 28.2. Layers of wall of the small intestine. The individual layers and their prominent features are represented schematically. Chapter 28. Small intestine. 1222. Part Roman 2. Specific considerations. Stomach superior mesenteric duodenum artery. Proximal limb of prim. Intestinal loop. Vital line duct. Distal limb of prim. Intestinal loop. A. Duodenum. Hepatic flexure. Ascending colon. Stomach transverse colon. Sacral butt. Vital line duct. Jejunal loop C. Transverse. 8 to 9 L of fluid enter the small intestine daily. Most of this volume, 1500 ml to colon, consists of salivary, gastric, biliary, pancreatic, and intestinal secretions. Under normal conditions, the small intestine absorbs figure 28.4. Small intestinal fluid fluxes. Typical quantities over 80. Vitamin B12 cobalamin malabsorption can result from a variety of surgical manipulations. The vitamin is initially bound by saliva-derived or protein. In the duodenum, our protein is hydrolyzed by pancreatic enzymes, allowing free cobalamin to bind to gastric parietal cell-derived intrinsic factor. The cobalamin intrinsic factor complex can escape hydrolysis by pancreatic enzymes, allowing it to reach the terminal ileum, which expresses specific receptors for intrinsic factor. Subsequent events in cobalamin absorption are poorly characterized, but the intact complex probably enters enterocytes through translocation. Because each of these steps is necessary for cobalamin assimilation, gastric resection, gastric bypass, and ileal resection can each result in vitamin B12 insufficiency. Other water-soluble vitamins for which specific care-immediate transport processes have been characterized include ascorbic acid, folate, thiamine, riboflavin, pantothenic acid, and biotin. Fat-soluble vitamins A, D, and E appear to be absorbed through passive diffusion. Vitamin K appears to be absorbed through both passive diffusion and carrier-mediated uptake. Calcium is absorbed through both transcellular transport and paracellular diffusion. The duodenum is the major site for transcellular transport. Paracellular transport occurs throughout the small intestine. A key step in transcellular calcium transport is mediated by calbindin, a calcium-binding protein located in the cytoplasm of enterocytes. Regulation of calbindin synthesis is the principal mechanism by which vitamin D regulates intestinal calcium absorption. Normal calcium levels are increasingly seen in surgical patients who have undergone a gastric bypass. Although usual calcium supplementation is often in the form of calcium carbonate, which is cheap, in such patients with low acid exposure, calcium citrate is a better formulation for supplemental therapy. Iron and magnesium are each absorbed through both transcellular and paracellular routes. A divalent metal transporter capable of transporting FeO+, ZnO+, MnO+, COPO+, CD4+, COPO+, NiPO+, and PB12+ that has been localized to the intestinal brush border may account for at least a portion of the transcellular absorption of these ions. 8. Barrier and immune function. Although the intestinal epithelium allows for the efficient absorption of dietary nutrients, it must discriminate between pathogens and harmless antigens such as food proteins and commensal bacteria, and it must resist invasion by other factors likely to play important roles in intestinal mucosal defense include antimicrobial peptides, such as the defenses. 9. The intestinal component of the immune system, known as the gut-associated lymphoid tissue gall, contains over 70% of the body's immune cells. The gall is conceptually divided into inductive and effector sites. 10. Inductive sites include Peyer's patches, mesenteric lymph nodes, and smaller isolated lymphoid follicles scattered throughout the small intestine. Fig. 28.10. Peyer's patches are macroscopic aggregates of B-cell follicles and intervening T-cell areas found in the lamina propria of the small intestine, primarily the distal ileum. Producing plasma cells are derived from B cells and are located in the lamina propria. CD4 plus T cells are also located in the lamina propria. CD8 plus T cells migrate preferentially to the epithelium, but they are also found in the lamina propria. These T cells are central to immune regulation. In addition, the CD8 plus T cells have potent cytotoxic CTL activity. It is transported through the intestinal epithelial cells into the lumen, where it exists in the form of a dimer complex with a secretory component. This configuration renders IgA resistant to proteolysis by digestive enzymes. IgA is believed to both help prevent the entry of microbes through the epithelium. The sites of the intestinal muscle layers are electrically and mechanically coordinated in the form of sensation. Contractions of the muscularis propria are responsible for small intestinal peristalsis. Contraction of the outer longitudinal muscle layer results in bowel shortening. Contraction of the inner circular layer results in luminal narrowing. Contractions of the muscularis mucosa contribute to mucosal or villus motility, but not to peristalsis. Several distinctive patterns of muscularis propria activity have been observed to occur in the small intestine. These patterns include ascending excitation and descending inhibition, in which muscular contraction occurs proximal to a stimulus, such as the presence of a bolus of ingested food, and muscular relaxation occurs distal to the stimulus. Fig. 28.11. These two reflexes are present even in the absence of any extrinsic innervation to the small intestine and contribute to peristalsis when they are propagated in a coordinated fashion along the length of the intestine. The fed or postprandial pattern begins within 10 to 20 minutes of meal ingestion and abates 4 to 6 hours afterwards. Rhythmic segmentations or pressure waves traveling only short distances also are observed. This segmenting pattern is hypothesized to assist in mixing intraluminal contents and in facilitating their contact with the absorptive mucosal surface. The fasting pattern or interdigestive motor cycle consists of 3 phases. Phase 1 is characterized by motor quiescence, Phase 2 by seemingly disorganized pressure waves occurring at submaximal rates, and Phase 3 by sustained pressure waves occurring at maximal rates. This pattern is hypothesized to expel residual debris and bacteria from the small intestine. The median duration of the IMC ranges from 90 to 120 minutes. At any given time, different portions of the small intestine can be in different phases of the small intestine has the capacity to adapt in response to varying demands imposed by physiologic and pathologic conditions. Relevance to many of the diseases discussed in this chapter is the adaptation that occurs in the remnant intestine following surgical resection of a large portion of the small intestine, massive small bowel resection. Post-resection intestinal adaptation has been studied extensively using animal models. Within a few hours after bowel resection, the remnant small intestine displays evidence of epithelial cellular hyperplasia. With additional time, villi lengthen, intestinal absorptive surface area increases, and digestive and absorptive functions improve. Post-resection intestinal adaptation in human patients is less well studied, but it seems to follow similar steps as that seen in experimental models, and it takes 1 to 2 years to complete. 13. The mechanisms responsible for inducing post-resection intestinal adaptation are under active investigation. Several classes of effectors that stimulate intestinal growth include specific nutrients, peptide hormones and growth factors, pancreatic secretions, and some cytokines. Nutritional components with intestinal growth stimulating effects include fiber, fatty acids, triglycerides, glutamine, polyamines, and lectins. Post-resection adaptation serves to compensate for the function of intestine that has been resected. Jejunal resection is generally better tolerated. Mechanical small bowel obstruction is the most frequently encountered surgical disorder of the small intestine. Although a wide range of etiologies for this condition exists, the obstructing lesion can be conceptualized according to its anatomical relationship to the intestinal wall as 1. 2. Intraluminal, for example, foreign bodies, gallstones, or meconium; intramural, for example, tumors, Crohn's disease, associated inflammatory strictures; extrinsic, for example, adhesions, hernias, or carcinomatosis. 3. Intra-abdominal adhesions related to prior abdominal surgery account for up to 75% of cases of small bowel obstruction. Over 300,000 patients are estimated to undergo surgery to treat 3 adhesion-induced small bowel obstruction in the United States annually. A 20-year trend analysis between 1988 and 2007 has documented no decrease in this rate during this period, highlighting the ongoing problem of this old disease. 14. In fact, small bowel resection and lysis of adhesions account for 2 of the 7 procedures that were responsible for 80% of the emergency surgeries in the United States between 2008 and 2011.15. Less prevalent etiologies for small bowel obstruction include hernias, malignant bowel obstruction, and Crohn's disease. The frequency with which obstruction related to these conditions is encountered varies according to the patient population and practice setting. Cancer-related small bowel obstructions are commonly due to extrinsic compression or invasion by advanced malignancies arising in organs other than the small bowel. Few are due to primary small bowel tumors. The most commonly encountered etiologies of small bowel obstruction are summarized in Table 28.3. Although congenital abnormality, 4 ties capable of causing small bowel obstruction usually become evident during childhood, they sometimes elude detection and are diagnosed for the first time in adult patients presenting with abdominal symptoms. For example, intestinal malrotation and midgut volvulus should not be forgotten when considering the differential diagnosis of adult patients with acute or chronic symptoms of small bowel obstruction, especially those without a history of prior abdominal surgery. A rare etiology of obstruction is the superior mesenteric artery syndrome, characterized by compression of the third portion of the duodenum by the superior mesenteric artery as it crosses over this portion of the duodenum. This condition should be Table 28.3. Small bowel obstruction. Common etiologies: adhesions, neoplasms. Primary small bowel neoplasms. Secondary small bowel cancer, considered in young asthenic individuals who have chronic symptoms suggestive of proximal small bowel obstruction. Pathophysiology: with onset of obstruction, gas and fluid accumulate within the intestinal lumen proximal to the site of obstruction. The intestinal activity increases to overcome the obstruction, accounting for the colicky pain and the diarrhea that some experience even in the presence of complete bowel obstruction. The symptoms of small bowel obstruction are colicky, abdomen. Obstruction include a discrete transition. The symptoms of strangulation, bowel obstruction, and it is the symptoms of small bowel obstruction are colicky, abdomen. Obstruction include a discrete transition zone with dilation of nausea, pain, nausea, Clinical presentation: the symptoms of small bowel obstruction are colicky, abdominal pain, nausea, vomiting, and obstipation. Vomiting is a more prominent symptom with proximal obstructions than distal. Character of vomitus is important, as with bacterial overgrowth, the vomitus is more feculent, suggesting a more established obstruction. Continued passage of flatus and slash or stool beyond 6 to 12 hours after onset of symptoms is characteristic of partial rather than complete obstruction. The signs of small bowel obstruction include abdominal distension, which is most pronounced if the site of obstruction is in the distal ileum and may be absent if the site of obstruction is in the proximal small intestine. Bowel sounds may be hyperactive initially, but in late stages of bowel obstruction, minimal bowel sounds may be heard. Laboratory findings reflect intravascular volume depletion and consist of hemoconcentration and electrolyte abnormalities. Mild leukocytosis is common. Features of strangulated obstruction include abdominal pain, often disproportionate to the degree of abdominal findings, suggestive of intestinal ischemia. Patients often have tachycardia, localized abdominal tenderness, fever, marked leukocytosis, and acidosis. Any of these findings should alert the clinician to the possibility of strangulation and the need for early surgical intervention. Diagnosis: the diagnostic evaluation should focus on the following goals: a distinguish mechanical obstruction from ileus, B, determine the etiology of the obstruction, C, discriminate partial from complete obstruction, and D, discriminate simple from strangulating obstruction. Important elements to obtain on history include prior abdominal operations suggesting the presence of adhesions and the presence of abdominal disorders, for example, intra-abdominal cancer or inflammatory bowel disease, that may provide insights into the etiology of obstruction. Upon examination, a meticulous search for hernias, particularly in the inguinal and femoral regions, should be conducted. The diagnosis of small bowel obstruction is usually confirmed with radiographic examination. The abdominal series consists of a radiograph of the abdomen with the patient in a supine position, B, a radiograph of the abdomen with the patient in an upright position, and C, a radiograph of the chest with the patient in an upright position. The finding most specific for small bowel obstruction is the triad of dilated small bowel, loops 3 cm in diameter, air fluid levels seen on upright films, and a paucity of air in the colon. The sensitivity of abdominal radiographs in the detection of small bowel obstruction ranges from 70% to 80%. Specificity is low because ileus and colonic obstruction can be associated with findings that mimic those observed with small bowel obstruction. False negative findings on radiographs can result when the site of obstruction is in the proximal small bowel and when the bowel lumen is filled with fluid but no gas, thereby preventing visualization of air fluid levels or bowel distension. The latter situation is associated with closed-loop obstruction. Despite these limitations, abdominal radiographs remain an important study in patients with suspected small bowel obstruction because of their widespread availability and low-cost. Fig. 2812. Computed tomographic CT scanning is becoming increasingly the imaging test of choice for patients with small bowel obstruction, and it is ideally done with oral contrast. CT is 80% to 90% sensitive and 70% to 90% specific in the detection of small bowel obstruction. The findings of small bowel obstruction include a discrete transition zone with dilation of bowel proximally, decompression of bowel distally, intraluminal contrast that does not pass beyond the transition zone, and a colon containing little gas or fluid. Figs. 2813 and 2814. CT scanning may also provide evidence for the presence of closed-loop obstruction and strangulation. Closed-loop obstruction is suggested by the presence of a U-shaped or C-shaped dilated bowel loop associated with a radial distribution of mesenteric vessels converging toward a torsion point. Strangulation is suggested by thickening of the bowel wall, pneumatosis intestinalis, air in the bowel wall, portal venous gas, mesenteric haziness, and poor uptake of intravenous contrast into the wall of the affected bowel. Fig. 2815. CT scanning also offers a global evaluation of the abdomen and may therefore reveal the etiology of obstruction. This feature is important in the acute setting when intestinal obstruction represents only one of many diagnoses in patients presenting with acute abdominal conditions. The CT scan is usually performed after administration of oral water-soluble contrast or diluted barium. Water-soluble contrast has been shown to have prognostic and therapeutic values too. Several studies and several subsequent meta-analyses have shown that water-soluble contrast could in fact have therapeutic and prognostic value. The appearance of the contrast. Figure 2812. Small bowel obstruction. Plain radiographs of B, erect, which confirm the presence of air fluid level in the obstruction. The colon within 24 hours of administration is predictive of non-surgical resolution of bowel obstruction with a sensitivity of 92% and a specificity of 93%. 16. The limitation of CT scanning is its low sensitivity, 50%, in the detection of low-grade or partial small bowel obstruction. A subtle transition zone may be difficult to identify in the axial images obtained during CT scanning. In such cases, contrast examinations of the small bowel, either small bowel series, small bowel follow-through, or enteroclysis, can be helpful. For standard small bowel series, contrast is swallowed or instilled into the stomach through a nasogastric tube. Abdominal radiographs are then taken serially as the contrast travels distally in the intestine. Although barium can be used, water-soluble. Figure 2813. Small bowel obstruction. A CT scan of a patient presenting with signs and symptoms of bowel obstruction. Image shows grossly dilated loops of small bowel with decompressed terminal ileumi and ascending colon C, suggesting that contrast agents, such as gastrografin, should be used if the possibility of intestinal perforation exists. These examinations are more labor-intensive and less rapidly performed than CT scanning, but may offer greater sensitivity in the detection of luminal and mural etiologies of obstruction, such as primary intestinal tumors. For enteroclysis, 200 to 250 ml of barium followed by 1 to 2 ml of a solution of methylcellulose in water is instilled into the proximal jejunum via a long nasoenteric catheter. The double contrast technique used in enterocolysis. Figure 2814. Chronic partial small bowel obstruction. This patient presented with a several months history of chronic abdominal pain and intermittent vomiting. The coronal CT image shows grossly dilated loops of proximal small bowel on the left side, wide arrow, with decompressed loops of small bowel on the right side, narrow arrow. The dilated segment shows evidence of fecalization of bowel contents, consistent with the chronic nature of the obstruction. Patient's vomitus had characteristic feculent smell and quality. At exploratory laparotomy, adhesive bands were identified and divided. Figure 2815. Intestinal pneumatosis. The CT scan shows intestinal pneumatosis error. The cause of this radiological finding was intestinal ischemia. Patient was taken emergently to the operating room and underwent resection of an infarcted segment of small bowel. Permits a better assessment of mucosal surface and detection of relatively small lesions, even through overlapping small bowel loops. Enterocolysis is rarely performed in the acute setting but offers greater sensitivity than small bowel series in the detection of lesions that may be causing partial small bowel obstruction. Recently, CT enterocolysis has been used, and it was reported to be superior to plain X-ray small bowel contrast studies. Therapy small bowel obstruction is usually associated with a marked depletion of intravascular volume due to decreased oral intake, vomiting, and sequestration of fluid in bowel lumen and wall. Therefore, fluid resuscitation is integral to treatment. Isotonic fluid should be given intravenously, and an indwelling bladder catheter may be placed to monitor urine output. Central venous or pulmonary artery catheter monitoring are not generally indicated unless the patient has underlying cardiac disease and severe dehydration. Broad-spectrum antibiotics are not indicated unless there is concern for bowel ischemia and surgery is planned. The stomach should be continuously evacuated of air and fluid using a nasogastric NG tube. Effective gastric decompression decreases nausea, distension, and the risk of vomiting and aspiration. Longer nasoenteric tubes, with tips placed into the jejunum or ileum, were favored in the past but are rarely used today, as they are associated with higher complication rates than NG tubes, with no proven greater efficacy in several studies. While a period of close observation and non-operative management has been the mainstay of treatment for partial bowel obstruction, the standard therapy for complete small bowel obstruction has generally been expeditious surgery, with the dictum that the sun should never rise and set on a complete bowel obstruction. The rationale for favoring early surgical intervention is to minimize the risk for bowel strangulation, which is associated with an increased risk for morbidity and mortality. Clinical signs and currently available laboratory tests and imaging studies do not reliably permit the distinction between patients with simple obstruction and those with strangulated obstruction prior to the onset of irreversible ischemia. Therefore, the goal is to operate before the onset of irreversible ischemia. This treatment approach has, however, undergone significant reassessment in recent years, with many advocating for non-operative approaches in management of these patients, providing closed-loop obstruction is ruled out and there is no evidence of intestinal ischemia. In a study of 145 patients with CT-diagnosed high-grade complete small bowel obstruction, 46% of the overall cohort were managed non-operatively. More specifically, of the 104 patients who did not meet criteria for immediate surgery, 66 patients were successfully managed non-operatively. 17. Thus, conservative therapy in the form of NG decompression and fluid resuscitation is now commonly recommended in the initial management of non-ischemic bowel obstruction. Non-operative management has been documented to be successful in 65% to 81% of patients with partial small bowel obstruction. Of those successfully treated non-operatively, only 5% to 15% have been reported to have symptoms that were not substantially improved within 48 hours after initiation of therapy. Therefore, most patients with partial small obstruction whose symptoms do not improve within 48 hours after initiation of non-operative therapy should be considered for surgery. In a study using the national inpatient sample, this principle was further highlighted. The authors concluded that a 2-day limit of watchful waiting before surgery is not associated with an increase in mortality or postoperative morbidity, although inpatient costs were higher. 18. The observation that administration of water-soluble oral contrast has not only diagnostic but also therapeutic and prognostic value has led to the creation of several protocols and pathways for management of patients presenting with small bowel obstruction. An example of such a pathway that is utilized at our institution is outlined in Fig. 2816. Several studies and subsequent meta-analyses have shown that use of water-soluble contrast not only predicts likelihood of success of non-operative management but also reduces the need for surgery. Odds ratio 0.44, length of stay by about 2 days, and time to resolution by about 28 hours without an increase in morbidity or mortality. 16. The operative procedure performed for small bowel obstruction varies according to the etiology of the obstruction. For example, adhesions are lysed, tumors are resected, and hernias are reduced and repaired. Regardless of the etiology, the affected intestine should be examined, and non-viable bowel should be resected. Criteria suggesting viability are normal color, peristalsis, and marginal arterial pulsations. Usually, visual inspection alone is adequate in judging viability. In borderline cases, a Doppler probe may be used to check for pulsatile flow to the bowel, and arterial perfusion can be verified by visualizing intravenously administered fluorescein dye in the bowel wall under ultraviolet illumination. Either technique has, however, been found to be superior to clinical judgment. In general, if the patient is hemodynamically stable, short lengths of bowel of questionable viability should be resected, and primary anastomosis of the remaining intestine should be performed. However, if the viability of a large proportion of the intestine is in question, a concerted effort to preserve intestinal tissue should be made. In such situations, the bowel of uncertain viability should be left intact and the patient re-explored in 24 to 48 hours in a second look operation. At that time, definitive resection of non-viable bowel is completed. Adhesive small bowel obstruction. Signs and symptoms of strangulation and intestinal ischemia. No, NPO IVF NG tube serial abdominal exam. 100 ml of water soluble contrast through NG. KUB after 8 hours. As contrast reach colon. No, repeat KUB after 24 hours. As contrast reach colon. Strongly consider surgery within 72 hours of admission. Figure 2816. Management of small bowel obstruction. Successful laparoscopic surgery for bowel obstruction is being reported with greater frequency. In a propensity score-matched study of patients who underwent a dialysis for small bowel obstruction, the laparoscopic approach was associated with significantly lower rates of overall complications, surgical site infections, and a shorter length of hospital stay 4 versus 10 days, 19. Since distended loops of bowel can interfere with adequate visualization, early cases of proximal small bowel obstruction that are likely due to a single adhesive band are best suited for this approach. Presence of bowel distension and multiple adhesions can cause these procedures to be difficult, with a reported conversion rate of 17% to 33%. One of the major concerns with the laparoscopic approach has been the risk of iatrogenic bowel injury. A pooled analysis of 11 non-randomized comparative studies has, however, shown that the risk of bowel injury and reoperation were not different between the two procedures, although the laparoscopic approach was associated with greater surgical time. 20. Outcomes. The perioperative mortality rate associated with surgery for non-strangulating small bowel obstruction is less than 5%. Operating room for exploration. High likelihood for non-op. The most deaths occurring in elderly patients with significant comorbidities. Mortality rates associated with surgery for strangulated obstruction is higher, highlighting the need for prompt intervention in this group. Long-term prognosis is related to the etiology of obstruction. Many patients who are treated conservatively for adhesive small bowel obstruction do not require future readmissions. Less than 20% of such patients will have a readmission over the subsequent 5 years with another episode of bowel obstruction. In a study of 286 patients who had undergone surgical intervention for adhesive small bowel obstruction, the risk of recurrent obstruction was 5% at 1 year, 3% at 3 years, and 5% at 5 years. The risk of reoperation for recurrent obstruction was 7% at 1 year, 8% at 3 years, and 8% at 5 years. 21. Considering the frequency of small bowel obstruction and the varied degree of clinical severity and presentation, there is often variation in the care of patients admitted with bowel obstruction. Studies have shown that a standard hospital-wide policy can help improve care of patients with bowel obstruction, reducing their time to surgery and shortening their length of hospital stay. 22. Prevention with adhesive small bowel obstruction representing a large therapeutic burden. Prevention of postoperative adhesions has become an area of great interest. Good surgical technique, careful handling of tissue, and minimal use and exposure of peritoneum to foreign bodies forms the cornerstone of adhesion prevention. These measures alone are often inadequate. In patients undergoing colorectal or pelvic surgery, hospital readmission rates of greater than 30% over the subsequent 10 years have been reported for adhesive small bowel obstruction. 23. Use of laparoscopic surgery, when possible, has been strongly promoted. A recent study using the Swedish National Inpatient Register has shown that, compared to laparoscopy, open surgery is associated with a 4-fold increase in risk of small bowel obstruction within 5 years of the index procedure, even after accounting for other risk factors such as age, comorbidity, and previous abdominal surgery. 24. In those undergoing open surgery, several strategies for adhesion prevention have been tried. However, the only therapy that has shown some success has been the use of hyaluronan-based agents, such as Sperafil. The use of this barrier has been clearly shown to reduce the incidence of postoperative bowel adhesions. However, their effect in actually reducing the incidence of small bowel obstruction remains less well defined. 25. The use of these products is often left to the discretion of the surgeon and the clinical context. Wrapping of an intestinal anastomosis with the material may be associated with increased leak rates and is generally discouraged. 26. Other causes of small bowel obstruction. Early postoperative bowel obstruction, as defined by signs, symptoms, and radiographic signs of SBO occurring within 30 days following surgery, been reported to occur in 7% to 9% of patients, with a higher rate in patients undergoing pelvic surgery, especially colorectal procedures. 27. CT scanning or small bowel series is often required to make the diagnosis. Obstruction that occurs in the early postoperative period is usually partial and only rarely is associated with strangulation. Therefore, a period of extended non-operative therapy 2-3 weeks consisting of bowel rest, hydration, and TPN administration is usually warranted. However, if complete obstruction is demonstrated or if signs suggestive of peritonitis are detected, expeditious reoperation should be undertaken without delay. In a series of 180 patients undergoing arterial resection for rectal cancer, 8% developed early postoperative bowel obstruction on the median postoperative day 5, with 4 requiring surgical exploration at a median interval of 2 weeks from the index case. 27. Crohn's disease as a cause of small bowel obstruction is discussed in more detail later in this chapter in the Crohn's disease section. Malignant small bowel obstruction can be a challenging problem, although it often indicates advanced disease with poor prognosis. 25% to 33% of patients with a history of cancer who present with small bowel obstruction have adhesions as the etiology of their obstruction and therefore should not be denied appropriate therapy. Even in cases in which the obstruction is related to recurrent malignancy, palliative resection or bypass can be performed, and in select cases these procedures lead to improved quality of life. In a series of 81 patients with small bowel obstruction, palliation was achieved in over 80% of patients, with over 70% able to reestablish oral intake. In this series, the surgical morbidity was high, with 7% developing an intrapercutaneous fistula/a lesion causing mechanical obstruction. Ileus is a temporary motility disorder that is reversed with time as the inciting Obvious carcinomatosis and multifocal obstruction pose a difficult challenge, given their limited prognosis. Thus, management must be tailored to an individual patient's prognosis and desires. At the time of surgery, relief of the obstruction may be best achieved by a bypass procedure, avoiding a potentially difficult bowel resection, and even if that is not feasible, a palliative gastrostomy tube can be considered to help resolve nausea and vomiting. Ileus and other disorders of intestinal motility. Ileus and intestinal pseudo-obstruction are clinical syndromes caused by impaired intestinal motility and are characterized by symptoms and signs of intestinal obstruction in the absence of. Frequently encountered factors are abdominal operations, infection and inflammation. The degree of intestinal ileus is a normal physiological response to abdominal surgery, which often resolves quickly without any long-term sequelae. However, when postoperative ileus is prolonged, it can cause significant morbidity and cost. Prolonged postoperative ileus is the most frequently implicated cause of delayed discharge following abdominal operations, and numerous factors capable of impairing intestinal motility, and thus inciting ileus, have been described. Table 28.4. The most Table 28.4 ileus. Common etiologies: abdominal surgery, infection, sepsis, intra-abdominal abscess, peritonitis, pneumonia, electrolyte abnormalities, hypokalemia, hypomagnesemia, hyponatremia. Medications: anticholinergics, opiates, phenothiazines, calcium channel blockers, tricyclic antidepressants, hypothyroidism, ureteral colic, retroperitoneal hemorrhage, spinal cord injury, myocardial infarction, mesenteric ischemia. Anastomotic leak and a 30-day mortality rate of 6%. 28. Patients with obvious carcinomatosis, infection and inflammation, electrolyte abnormalities, and drugs. Following most abdominal operations or injuries, the motility of the gastrointestinal tract is transiently impaired. Among the proposed mechanisms responsible for this dysmotility are surgical stress-induced sympathetic reflexes, inflammatory response mediator release, and anesthetic/analgesic side effects, each of which can inhibit intestinal motility. The return of normal motility generally follows a characteristic temporal sequence, with small intestinal motility returning to normal within the first 24 hours after laparotomy and gastric and colonic motility returning to normal by 48 hours and 2 to 5 days, respectively. Since small bowel motility is returned before colonic and gastric motility, listening for bowel sounds is not a reliable indicator that ileus has fully resolved. Functional evidence of coordinated gastrointestinal motility in the form of passing flatus or bowel movement is a more useful indicator. Resolution of ileus may be delayed in the presence of other factors capable of inciting ileus, such as the presence of intra-abdominal abscesses or electrolyte abnormalities. Chronic intestinal pseudo-obstruction can be caused by a large number of specific abnormalities affecting intestinal smooth muscle, the myenteric plexus, or the extraintestinal nervous system. Table 28.5. Visceral myopathies constitute a group of diseases characterized by degeneration and fibrosis of the intestinal muscularis propria. Visceral neuropathies encompass a variety of degenerative disorders of the myenteric and submucosal plexuses. Both sporadic and familial forms of visceral myopathies and neuropathies exist. Systemic disorders involving the smooth muscle, such as progressive systemic sclerosis and progressive muscular dystrophy, and neurological diseases such as Parkinson's disease, can also be complicated by chronic intestinal pseudo-obstruction. In addition, viral infections, such as those associated with cytomegalovirus and Epstein-Barr virus, can cause intestinal pseudo-obstruction. Table 28.5. Chronic intestinal pseudo-obstruction. Etiology's primary cause is familial types. Familial visceral myopathies types I, Roman II, and Roman III. Familial visceral neuropathies types I and Roman II. Childhood visceral myopathies types I and Roman II. Sporadic types. Visceral myopathies, visceral neuropathies. Secondary causes: smooth muscle disorders. Collagen vascular diseases, for example. Scleroderma muscular dystrophies, for example. Myotonic dystrophy, amyloidosis, neurological disorders. Chagas disease, Parkinson's disease, spinal cord injury, endocrine disorders, diabetes, hypothyroidism, hypoparathyroidism, miscellaneous disorders. Radiation. Clinical presentation of ileus resembles that of small bowel obstruction. Ability to tolerate liquids and solids by mouth, nausea, and lack of flatus or bowel movements are the most common symptoms. Vomiting and abdominal distension may occur. Although bowel sound characteristics are not diagnostic, they are usually diminished or absent, in contrast to the hyperactive bowel sounds that usually accompany mechanical small bowel obstruction. The clinical manifestations of chronic intestinal pseudo-obstruction include variable degrees of nausea and vomiting and abdominal pain and distension. Diagnosis: routine postoperative ileus should be expected and requires no diagnostic evaluation. Definition of prolonged postoperative ileus has been varied but generally diagnosed if ileus persists beyond 5 days postoperatively. A recent global survey synthesized the results of the data to define postoperative ileus as interval from surgery until passage of flatus/stool and tolerance of an oral diet, with prolonged postoperative ileus being defined as 2 or more of nausea/vomiting, inability to tolerate oral diet over 24H, absence of flatus over 24H, distension, radiologic confirmation occurring on or after day 4 postoperatively without prior resolution of postoperative ileus. 30. Prolonged ileus is reported to occur in 10% to 15% of patients undergoing intestinal surgery. 31. Once suspected, diagnostic evaluation to detect specific underlying factors capable of inciting ileus and to rule out the presence of mechanical obstruction is warranted. Patient medication lists should be reviewed for the presence of drugs, especially opiates, known to be associated with impaired intestinal motility. Measurement of serum electrolytes may demonstrate electrolyte abnormalities commonly associated with ileus. Abdominal radiographs are often obtained, but the distinction between ileus and mechanical obstruction may be difficult based on this test alone. In the postoperative setting, CT scanning is the test of choice as it can demonstrate the presence of an intra-abdominal abscess or other evidence of peritoneal sepsis that may be causing ileus and can exclude the presence of complete mechanical obstruction. Distinction of postoperative ileus from early postoperative obstruction can be difficult, but is helpful in developing the appropriate management plan. The diagnosis of chronic pseudo-obstruction is suggested by clinical features and confirmed by radiographic and manometric studies. Diagnostic laparotomy or laparoscopy with full-thickness biopsy of the small intestine may be required to establish the specific underlying cause in cases of suspected neural disorder. Therapy. The management of ileus consists of limiting oral intake and correcting the underlying inciting factor. If vomiting or abdominal distension are prominent, the stomach should be decompressed using a nasogastric tube. Fluid and electrolytes should be administered intravenously until ileus resolves. If the duration of ileus is prolonged, total parenteral nutrition (TPN) may be required. Given the frequency of postoperative ileus and its financial impact, many strategies have been tested to reduce its duration. The administration of non-steroidal anti-inflammatory drugs such as ketorolac and concomitant reductions in opioid dosing have been shown to reduce the duration of ileus in most studies. Similarly, the use of perioperative inflammation represents an appropriate response to a yet unrecognized pathogen or an inappropriate response to a normally innocuous stimulus is unknown. Various hypotheses on the roles of environmental and genetic factors in the pathogenesis of Crohn's disease have been proposed. Many infectious agents have been suggested to be the causative organism of Crohn's disease. However, there has been no conclusive evidence to confirm any. Studies using animal models suggest that in a genetically susceptible host, a non-pathogenic gut microbiome is sufficient to induce a chronic inflammatory response resembling that associated with Crohn's disease. In these models, the sustained intestinal inflammation is the result of either abnormal epithelial barrier function or immune dysregulation. Full discussion of the role of gut immune system and microbiome in the development of Crohn's disease is beyond the scope of this work, but it is an area of great interest and under investigation. In general, poor barrier function is hypothesized to permit inappropriate exposure of lamina propria lymphocytes to antigenic stimuli derived from the intestinal lumen. In addition, a variety of defects in immune regulatory mechanisms, for example, overresponsiveness of mucosal T cells to enteric flow are derived. Clinical presentation. The most common symptoms of Crohn's disease are abdominal pain, diarrhea, and weight loss. However, the clinical features are highly variable among individual patients and depend on which segment S of the gastrointestinal tract are predominantly affected, the intensity of inflammation, and the presence or absence of specific complications. In fact, some patients with Crohn's disease may have been initially misdiagnosed as having irritable bowel syndrome or celiac disease. Patients can be classified by their predominant clinical manifestation as having primarily a fibrostenotic disease, a fistulizing disease, and C. aggressive inflammatory disease. There is substantial overlap among these disease patterns in individual patients. However, the onset of symptoms is insidious, and once present, their severity follows a waxing and waning course. Constitutional symptoms, particularly weight loss and fever, or growth retardation in children, may also be prominent and are occasionally the sole presenting features of Crohn's disease. The disease affects the small bowel in 80% of cases and colon alone in 20%. In those with small bowel disease, the majority have ileocecal disease. Isolated perineal and anortal disease occurs in 5% to 10% of affected patients. And common sites of involvement include the esophagus, stomach, and duodenum. An estimated 1/4 of all patients with Crohn's disease will have an extraintestinal manifestation of their disease. On Table 28.7, extraintestinal manifestations of Crohn's disease: dermatologic, erythema nodosum, pyoderma gangrenosum, rheumatologic, peripheral arthritis, ankylosing spondylitis, sacroiliitis ocular, conjunctivitis, uveitis/uritis, episcleritis, hepatobiliary, hepatic steatosis, cholelithiasis, primary sclerosing cholangitis, pericholangitis, urologic, nephrolithiasis, ureteral obstruction, miscellaneous, thromboembolic disease, vasculitis, osteoporosis, endocarditis, myocarditis, pleuroprecarditis, interstitial lung disease, amyloidosis, pancreatitis. 1/4 of those affected will have more than one manifestation. Many of these complications can be seen with both Crohn's disease and ulcerative colitis, although they are more prevalent among patients with Crohn's disease. The most common extraintestinal manifestations are listed in Table 28.7. The clinical severity of some of these manifestations, such as erythema nodosum and peripheral arthritis, are correlated with the severity of intestinal inflammation. The severity of other manifestations, such as pyoderma gangrenosum and ankylosing spondylitis, bear no apparent relationship to the severity of intestinal inflammation. Diagnosis. The diagnosis is usually established with endoscopic findings in a patient with a compatible clinical history. The diagnosis should be considered in those presenting with acute or chronic abdominal pain, especially when localized to the right lower quadrant, chronic diarrhea, evidence of intestinal inflammation on radiography or endoscopy, the discovery of a bowel stricture or fistula arising from the bowel, and evidence of inflammation or granulomas on intestinal histology. Disorders associated with clinical presentations that resemble those of Crohn's disease include ulcerative colitis, functional bowel disorders such as irritable bowel syndrome, mesenteric ischemia, collagen vascular diseases, carcinoma and lymphoma, diverticular disease, and infectious enteritis. Infectious enteritis are most frequently diagnosed in immunocompromised patients, but they can also occur in patients with normal immune function. Acute ileitis caused by Campylobacter and Yersinia species can be difficult to distinguish from that caused by an acute presentation of Crohn's disease. Typhoid enteritis caused by Salmonella. Typhosis can lead to overt intestinal bleeding and perforation, most often affecting the terminal ileum. The distal ileum and cecum are the most common sites of intestinal involvement by infection due to Mycobacterium tuberculosis. This condition can result in intestinal inflammation, strictures, and fistula formation, like those seen in Crohn's disease. Cytomegalovirus CMV can cause intestinal ulcers, bleeding, and perforation. No single symptom, sign, or diagnostic test establishes the diagnosis of Crohn's disease. Instead, the diagnosis is based on a complete assessment of the clinical presentation with confirmatory findings derived from radiographic, endoscopic, and in most cases, pathologic tests. Patients presenting with a history of Crohn's disease should have their full blood count, electrolytes and renal function, liver function, iron, B12, ESER, and CRP levels checked. The results may be abnormal, showing anemia, but these results are non-diagnostic. Colonoscopy with intubation of terminal ileum is the main diagnostic tool and can reveal focal ulcerations adjacent to areas of normal-appearing mucosa along with polypoid mucosal changes that give a cobblestone appearance. Skip areas of involvement are typical with segments of normal-appearing bowel interrupted by large areas of obvious disease. This pattern is different from the continuous involvement in ulcerative colitis. Pseudopolyps, as seen in ulcerative colitis, are also often present. Barium small bowel follow-through, CT enterography, or Mr. enterography may be used as contrast examinations of the small bowel to reveal strictures or networks of ulcers and fissures. CT scanning may reveal intra-abdominal abscesses and is useful in acute presentations to rule out the presence of other intra-abdominal disorders. Esophagogastrocholescopy EGD is done for disease of the proximal alimentary tract. Because Crohn's disease often affects the small bowel, which is difficult to image, capsule endoscopy has been increasing use to make this diagnosis. Figure 81840. Figure 2818. Several antibodies have also been identified in patients with inflammatory bowel disease, which may have diagnostic value. Most commonly tested antibodies are antineutrophil cytoplasmic antibody P-ANCA and anti-Saccharomyces cerevisiae antibody ESCAN. ESCAN+/P-ANCA is associated with the diagnosis of Crohn's disease, while ESCAN/P-ANCA+ correlates with ulcerative colitis. Although these antibody tests have high specificity, their use has been hampered by low test sensitivities. There is ongoing interest in developing other antibodies. The need for surgery for Crohn's disease has decreased steadily over the past few decades. Recent meta-analysis estimated the risk of surgery to be 16, 3%, 33, 3%, and 46, 6% at 1, 5, and 10 years respectively. 41. Surgery is generally reserved for patients whose disease is unresponsive to aggressive medical therapy or who develop complications of their disease. Table 28.8. Failure of medical management may be the indication for surgery if symptoms persist despite aggressive therapy for several months or if symptoms recur whenever aggressive therapy is tapered. Surgery should be considered if medication-induced complications arise, specifically corticosteroid-related complications, such as Cushingoid features, cataracts, glaucoma, systemic hypertension, compression fractures, or septic necrosis of the femoral head. Growth retardation constitutes an indication for surgery in 30% of children with Crohn's disease. One of the most common indications for surgical intervention is intestinal obstruction. Abscesses and fistulas are frequently encountered during operations performed for intestinal obstruction in these patients, but they are rarely the only indication for surgery. Most abscesses are amenable to percutaneous drainage, and fistulas, unless associated with symptoms or metabolic derangements, do not require surgical intervention. Less common complications that require surgical intervention are acute gastrointestinal hemorrhage, perforations, and development of cancer. Although surgery for Crohn's disease is usually planned, and uncommon, but not rare, scenario is the intraoperative discovery of inflammation limited to the terminal ileum during operations performed for presumed appendicitis. This scenario can result from an acute presentation of Crohn's disease or from acute ileitis caused by bacteria such as Yersinia or Campylobacter. Both conditions should be treated medically. Ileoresection is not generally indicated. However, the appendix, even if normal appearing, should be removed unless the cecum is inflamed, increasing the potential morbidity of this procedure to eliminate appendicitis from the differential diagnosis of abdominal pain in these patients, particularly those with Crohn's disease who may be destined to have recurring symptoms. When the diagnosis of Crohn's disease is known and surgery is planned, a thorough examination of the entire intestine should be performed. The presence of active disease is suggested by thickening of the bowel wall, narrowing of the lumen, serosal inflammation and coverage by creeping fat, and thickening of mesentery. Skip lesions are present in approximately 20% of cases and should be sought. The length of uninvolved small intestine should be noted. Segmental intestinal resection of grossly evident disease followed by primary anastomosis is the usual procedure of choice. Microscopic evidence of Crohn's disease at the resection margins does not compromise a safe anastomosis, and frozen section analysis of resection margins is unnecessary. In a randomized prospective trial, the effects of achieving 2 cm resection margins beyond grossly evident disease were compared with achieving 12 cm resection margins, 42. There were no evident differences with respect to clinical recurrence rates or anastomotic recurrences. Recurrence rates were similar whether margins were histologically free or involved with Crohn's disease. An area of controversy in surgical management of Crohn's disease has been the ideal anastomotic technique for the bowel after intestinal resection. This issue was addressed in a randomized study of 139 patients undergoing an ileocolic resection for Crohn's disease, with a mean follow-up of 11.9 months. There were no differences in endoscopic or symptomatic disease recurrence between the groups reconstructed using end-to-end suture 2.0 PDS anastomosis versus those with side-to-side staples anastomosis. 43. An alternative to segmental resection for obstructing lesions is stricturoplasty Fig. 2819. This technique allows for preservation of intestinal surface area and is especially well suited to patients with extensive disease and fibrotic strictures who may have undergone previous resection and are at risk for developing short bowel syndrome. In this technique, The bowel is open longitudinally to expose the lumen. Any 8b figure 2819. Stricturoplasty. The wall of the strictured bowel is incised longitudinally. Reconstruction is performed by closing the defect transversely in a manner similar to the Hynek-Mikulicz pyloroplasty for short strictures A, or the Finney pyloroplasty for longer strictures B. Intraluminal ulcerations should be biopsied to rule out the presence of neoplasia. Depending on the length of the stricture, the reconstruction can be fashioned in a manner similar to the Hynek-Mikulicz pyloroplasty for strictures less than 12 cm in length or the Finney pyloroplasty for longer strictures as much as 25 cm in length. For longer strictures, variations on the standard stricturoplasty, namely the side-to-side isoperistaltic enteroenterostomy, have been indicated and used for strictures with mean lengths of 50 cm, 44. Stricturoplasty sites should be marked with metallic clips to facilitate their identification on radiographs and during subsequent operations. Stricturoplasty is associated with recurrence rates that are no different from those associated with segmental resection. Because the affected bowel is left in situ rather than resected, there is the potential for cancer developing at the stricturoplasty site. However, as data on this complication are limited to anecdotes, this risk remains a theoretical one. Stricturoplasty is contraindicated in patients with intra-abdominal abscesses or intestinal fistulas. The presence of a solitary stricture relatively close to a segment for which resection is planned is a relative contraindication. In general, stricturoplasty is performed in cases where single or multiple strictures are identified and diffusely involve segments of bowel, or where previous resections have been performed and maintenance of intestinal length is of great importance. Intestinal bypass procedures are sometimes required in the presence of intramesenteric abscesses or if the diseased bowel is coalesced in the form of a dense inflammatory mass, making its mobilization unsafe. Bypass procedures gastrojejunectomy are also used in the presence of duodenal strictures, for which stricturoplasty and segmental resection can be technically difficult. Since the 1990 seconds, laparoscopic surgical techniques have been applied to patients with Crohn's disease. The inflammatory changes associated with Crohn's disease, such as thickened and foreshortened mesentery, obliterated tissue planes, and free blood tissues with engorged vasculature can make laparoscopic approach challenging. Randomized studies and a meta-analysis have confirmed that laparoscopic surgery for Crohn's disease is associated with less postoperative pain, shorter duration of ileus, and a shorter hospital stay. The rates of disease recurrence were similar between the two groups, 45. Outcomes overall complication rates following surgery for Crohn's disease range from 15% to 30%. Wound infections, postoperative intra-abdominal abscesses, and anastomotic leaks account for most of these complications. Surgery is not a curative intervention in Crohn's disease, and many patients develop recurrence. If recurrence is defined endoscopically, 70% recur within 1 year of a bowel resection and 85% by 3 years, 46. Clinical recurrence, defined as the return of symptoms confirmed as being due to Crohn's disease, affects 60% of patients by 5 years and 94% by 15 years. Fistula is defined as an abnormal communication between two epithelialized surfaces. The communication occurs between two parts of the gastrointestinal tract or adjacent organs in an internal fistula, for example, interocolonic fistula or colovesicular fistula. An external fistula, for example, interocutaneous fistula or rectovaginal fistula, involves the skin or another external surface epithelium. Interocutaneous fistulas that drain less than 200 ml of fluid per day are known as low output fistulas, whereas those that drain more than 500 ml of fluid per day are known as high output fistulas. Over 80% of interocutaneous fistulas represent iatrogenic complications that occur as the result of enterotomies or intestinal anastomotic dehiscences. Fistulas that arise spontaneously without antecedent iatrogenic injury are usually manifestations of progression of underlying Crohn's disease or cancer. Pathophysiology: the manifestations of fistulas depend on which structures are involved. Low resistance enteroenteric fistulas, which allow luminal contents to bypass a significant proportion of the small intestine, may result in clinically significant malabsorption. Enterossecular fistulas often cause recurrent urinary tract infections. The drainage emanating from interocutaneous fistulas are irritating to the skin and cause excoriation. Iatrogenic interocutaneous fistulas usually become clinically evident between the 5th and 10th postoperative days. Fever, leukocytosis, prolonged ileus, abdominal tenderness, and wound infection are the initial signs. The diagnosis becomes obvious when drainage of enteric material through the abdominal wound or through existing drains occurs. These fistulas are often associated with intra-abdominal abscesses. Diagnosis: CT scanning following the administration of enterocontrast is the most useful initial test. Leakage of contrast material from the intestinal lumen can be observed. Intra-abdominal should be sought and drained percutaneously. If the anatomy of the fistula is not clear on CT scanning, a small bowel series or enteroclysis examination can be obtained to demonstrate the fistula site of origin in the bowel. This study is also useful to rule out the presence of intestinal obstruction distal to the site of origin. Occasionally, contrast administered into the intestine does not demonstrate the fistula tract. A fistulogram, in which contrast is injected under pressure through a catheter placed percutaneously into the fistula tract, may offer greater sensitivity in localizing the fistula origin. Therapy: the treatment of interocutaneous fistulas should proceed through an orderly sequence of steps. 48. 1. Stabilization. Fluid and electrolyte resuscitation is begun. Nutrition is provided, usually through the parenteral route initially. Sepsis is controlled with antibiotics and drainage of abscesses. The skin is protected from the fistula effluent with ostomy appliances or fistula drains. 2. Investigation. The anatomy of the fistula is defined using the aforementioned studies. 3. Decision. The available treatment options are considered, and a timeline for conservative measures is determined. 4. Definitive management. This entails the surgical procedure and requires appropriate preoperative planning and surgical experience. 5. Rehabilitation. The overall objectives are to increase the probability of spontaneous closure. Nutrition and time are the key components of this approach. Most patients will require TPN. However, a trial of oral or enteral nutrition should be attempted in patients with low output fistulas originating from the distal intestine. Somatostatin analog octreotide is a useful adjunct, particularly in patients with high output fistulas. A meta-analysis of several randomized studies confirmed that somatostatin treatment reduced length of hospital stay and time to closure of fistulas. However, its administration did not lead to a significant difference in fistula closure rates. 49. Use of negative pressure wound therapy has increased in management of interarcutaneous fistulas. The system can allow better management of the fistula output. In a study of 91 patients with interarcutaneous fistulas, 40% of fistulae reached minimal output within a week, and with an average follow-up of 90 days, spontaneous closure rate was 46%. 50. Timing of surgical intervention. Most surgeons would pursue 2 to 3 months of conservative therapy before considering surgical intervention. This approach is based on evidence that 90% of fistulas that are going to close do so within 5 weeks, and that surgical intervention after this period is associated with better outcomes and lower morbidity. 51. If the fistula fails to resolve during this period, surgery may be required, during which the fistula tract, together with the segment of intestine from which it originates, should be resected. Simple closure of the opening in the intestine from which the fistula originates is associated with high recurrence rates. Patients with intestinal fistulas typically have extensive and dense intra-abdominal adhesions. Thus, operations performed for non-healing fistulas can present formidable challenges. Successful applications of alternative therapies to close intestinal fistulas, such as the use of biologic sealants, have been reported. The indications for their use remain to be defined. Outcomes: over 50% of intestinal fistulas close spontaneously. The useful mnemonic designates factors that inhibit spontaneous closure of intestinal fistulas: foreign body within the fistula tract, radiation enteritis, infection/inflammation at the fistula origin, epithelialization of the fistula tract, neoplasm at the fistula origin, distal obstruction of the intestine. In a 23-year-old retrospective review of 153 cases of interarcutaneous fistulas that were treated surgically, most fistulas were found to originate from the small bowel and be iatrogenic in nature, with patients having undergone 5 or more previous abdominal surgeries. Operative repair was associated with a 30-day mortality of approximately 4% and a 1-year mortality of 15%. Morbidity was over 80%. First attempt at surgical repair was successful in 70% of cases, with an overall closure rate of 84% and some patients requiring up to 3 attempts at surgical repair. The authors identified closure of the abdominal fascia as an important factor in reducing rates of refistulization and postoperative mortality. 52. In another similar study, fistula recurrence rates of 30% were documented and were independently associated with high output fistulas, and the type of surgical treatment, operations not involving resection of the fistula, had a much higher rate of recurrence. Adenomas are the most common benign neoplasm of the small intestine. Other benign tumors include fibromas, lipomas, hemangiomas, lymphangiomas, and neurofibromas. The prevalence of small bowel tumors identified in autopsy is 0, 2% to 0, 3%, which is significantly higher than the rate of operation for small bowel. Duodenal polyps, as detected during EGD performed for other reasons, range from 0, 3% to 4, 6%. Benign neoplasms account for 30% to 50% of small bowel tumors and include adenomas, lipomas, hematomas, and hemangiomas. Primary small bowel cancers are rare but have been increasing in incidence, with an estimated incidence of 10,190 cases in 2017 in the United States. Among small bowel cancers, adenocarcinomas comprise 35% to 50% of all cases, carcinoid tumors comprise 20% to 40%, and lymphomas comprise approximately 10% to 15%. In a retrospective review of a large U.S. database year between 1992 and 2006, of a total number of 10,945 small intestine cancers, 4,315 were neuroendocrine in origin, 3,412 were carcinomas, 2,023 were part of the KIT. Most small intestinal neoplasms are asymptomatic until they become large. Partial small bowel obstruction, with associated symptoms of crampy abdominal pain and distension, nausea, and vomiting, is the most common mode of presentation. Obstruction can be the result of either luminal narrowing by the tumor itself or intussusception, with the tumor serving as the lead point. Hemorrhage, usually indolent, is the second most common mode of presentation. Physical examination may be unrevealing, but it also may reveal a palpable abdominal mass in those with large tumors. Findings of intestinal obstruction may be present in some patients. Fecal occult blood test may be positive. Jaundice secondary to biliary obstruction or hepatic metastasis may be present. Cachexia, hepatomegaly, and ascites may be present with advanced disease. Although the clinical presentation is usually not specific for tumor type, some general comments are appropriate. Adenocarcinomas, as well as adenomas from which most are believed to arise, are most commonly found in the duodenum. Diagnosis: because of the absent or non-specific symptoms associated with most small intestinal neoplasms, these lesions are rarely diagnosed preoperatively. Laboratory tests are non-specific, except for elevated urinary 5-hydroxyindoleacetic acid 5-higher and serum chromogranin CGL levels in patients with carcinoid syndrome, both of which have low sensitivity. Elevated carcinoembryonic antigen CA levels are associated with small intestinal adenocarcinomas, but only in the presence of liver metastasis. Contrast radiography of the small intestine may demonstrate benign and malignant lesions. Enterocolysis is reported to have a sensitivity of over 90% in the detection of small bowel tumors and is the test of choice, particularly for tumors located in the distal small bowel. Upper GI with small bowel follow-through examinations have reported sensitivities ranging from only 30% to 44% Fig. 2823. CT scanning can detect abnormalities in 70% to 80% of cases with small bowel tumor and assess for metastatic spread. Tumors associated with significant bleeding can be localized with angiography or radioisotopic red blood cell RBC scans. Tumors located in the duodenum can be visualized and biopsied on EGD. In addition, endoscopic ultrasonography EUS can offer additional information such as the layers of the intestinal wall involved by the lesion. Occasionally, the distal ileum can successfully be visualized during colonoscopy. Intraoperative enteroscopy can be used to directly visualize small intestinal tumors beyond the reach of standard endoscopic techniques. For more distal small bowel lesions, capsule endoscopy and double balloon. Figure 2822, jejunal gastrointestinal stromal tumor GIS. This patient presented with overt obscure GI bleeding and was found to have a 7 cm jejunal GIS. The picture represents the laparoscopic view of the masked black arrow, rising from the endomesenteric side of the small bowel asterisk. He underwent a successful laparoscopic resection. Figure 2823, small bowel lesion identified during the small bowel follow-through arrow. This patient had previously had a metastatic renal lesion to his duodenum requiring a Whipple procedure. During follow-up imaging 3 years later, he was found to have this new lesion in his jejunum. He underwent a laparoscopic small bowel resection. Pathology revealed a benign jejunal sessile polyp. Endoscopy have been used to evaluate small bowel. CT and Mr. Enterography are also increasingly utilized as non-invasive tests to look for small bowel. Radiation therapy is a component of multimodality therapy for many intra-abdominal and pelvic cancers, such as those of the cervix, endometrium, ovary, bladder, prostate, and rectum. And small intestinal epithelium is acutely to the small intestine, which can present clinically as two distinct syndromes, acute and chronic radiation enteritis. Diagnosis evaluation of patients suspected of having chronic undesired side effect of radiation therapy is radiation-induced injury to the small intestine, which can present clinically as two distinct syndromes, acute and chronic radiation enteritis. Acute radiation enteritis is a transient condition that occurs in approximately 75% of patients undergoing radiation therapy for abdominal and pelvic cancers. Chronic radiation enteritis is inexorable and develops in approximately 5% to 15% of these patients. Pathophysiology: radiation induces cellular injury directly and through the generation of free radicals. The principal mechanism of radiation-induced cell death is believed to be apoptosis resulting from free radical-induced breaks in double-stranded DNA, because radiation has its greatest impact on rapidly proliferating cells. Figure 2825, radiation enteritis. This contrast radiograph reveals widely separated loop. Radiation induces cellular injury directly and through the generation of free radicals. The principal mechanism of radiation-induced cell death is believed to be apoptosis resulting from free radical-induced breaks in double-stranded DNA, because radiation has its greatest impact on rapidly proliferating cells. Figure 2825, radiation enteritis. This contrast radiograph. Clinical presentation: the most common manifestations of acute radiation enteritis are nausea, vomiting, diarrhea, and crampy abdominal pain. Symptoms are generally transient and subside after the discontinuation of radiation therapy. Because the diagnosis is usually obvious, given the clinical context, no specific diagnostic tests are required. However, if patients develop signs suggestive of peritonitis, CT scanning should be performed to rule out the presence of other conditions capable of causing acute abdominal syndromes. The clinical manifestations of chronic radiation enteritis usually become evident within 2 years of radiation administration, although they can begin as early as several months or as late as decades afterwards. Most common clinical presentations are diarrhea or one or partial small bowel obstruction with nausea, vomiting, intermittent abdominal distension, crampy abdominal pain, and weight loss. The terminal ileum is the most frequently affected segment. Other manifestations of chronic radiation enteritis include complete bowel obstruction, acute or chronic intestinal hemorrhage, and abscess or fistula formation. Diagnosis evaluation of patients suspected of having chronic radiation enteritis should include review of the records of their undesired side effect of radiation therapy is radiation-induced injury to radiation treatments. For information on total radiation dose administered, fractionation, and volume of treatment. Areas that receive high doses should be noted, as lesions subsequently found in imaging studies usually localized to areas that had received high radiation doses. Enterocolysis is the most accurate imaging test for diagnosing chronic radiation enteritis, with reported sensitivities and specificities of over 90%. Fig. 2825. CT scan findings are neither very sensitive nor specific for chronic radiation enteritis. However, CT scanning should be obtained to rule out the presence of recurrent cancer since its clinical manifestations may overlap with those of chronic radiation enteritis. Therapy: most cases of acute radiation enteritis are self-limited. Supportive therapy, including the administration of antiemetics, is usually sufficient. Patients with diarrhea-induced dehydration may require hospital admission and parenteral fluid administration. Rarely are symptoms severe enough to necessitate reduction in or cessation of radiation therapy. In contrast, the treatment of chronic radiation enteritis represents a formidable challenge. Antidiarrheal agents may have a role in the management of diarrhea, while, in those with obstructive symptoms, a low-residue diet may be tried. Surgery for this condition is difficult, is associated with high morbidity rates, and should be avoided in the absence of specific indications such as high-grade obstruction, perforation, hemorrhage, intra-abdominal abscesses, and fistulas. The goal of surgery is limited resection of diseased intestine with primary anastomosis between healthy bowel segments. However, the characteristically diffuse nature of fibrosis and dense adhesions among bowel segments can make limited resection difficult to achieve. Further, it is difficult to distinguish between normal and irradiated intestine intraoperatively by either gross inspection or even frozen section analysis. This distinction is important as anastomosis between irradiated segments of intestine have been associated with leak rates as high as 50%, 58. If limited resection is not achievable, an intestinal bypass procedure may be an option, except in cases for which hemorrhage is the surgical indication. There remain cases in which resections extensive enough to cause short bowel syndrome are unavoidable. This condition is discussed in detail below in the short bowel syndrome section. Outcomes: acute radiation injury to the intestine is self-limited. Its severity is not correlated with the probability of chronic radiation enteritis developing. Surgery for chronic radiation enteritis is associated with high morbidity rates and reported mortality rates averaging 10%. Prevention: in view of significant morbidity associated with radiation enteritis, groups have studied possible measures to reduce or prevent such side effects. Keeping radiation exposure to below 5,000 CGI is associated with minimal long-term side effects and is recommended where clinically possible. Uses of multi-beam radiation techniques to minimize the area of maximal radiation exposure, as well as tilt tables to move the bowel out of the pelvic during radiation, are increasingly utilized. Few small studies have suggested that oral sulfasalazine may help reduce the incidence of acute radiation-induced enteritis. 59. In patients undergoing pelvic surgery that are likely to require postoperative radiation therapy, surgical techniques that keep the small bowel out of the pelvic have been recommended. These measures include use of absorbable mesh sling to separate the pelvic from the true abdominal cavity and prevent the small bowel from being exposed to pelvic radiation. 60. Mecos diverticulum. Mecos diverticulum is the most prevalent congenital anomaly of the gastrointestinal tract, affecting approximately 2% of the general population. Mecos diverticuli are designated true diverticuli because their walls contain all the layers found in normal small intestine. Their location varies among individual patients, but they are usually found in the ileum within 100 cm of the ileocecal valve. Fig. 28-26. Approximately 60% of Mecos diverticuli contain heterotopic mucosa, of which over 60% consist of gastric mucosa. Pancreatic acini are the next most common. Others include Brunner's glands, pancreatic islets, colonic mucosa, endometriosis, and hepatobiliary tissues. Useful, although crude, mnemonic describing Mecos diverticuli is the rule of twos. 2% prevalence, 2, 1 male predominance, location 2 feet proximal to the ileocecal valve in the doves, and half of those who are symptomatic are under 2 years of age. Pathophysiology: during the 8th week of gestation, the surgical treatment of symptomatic Mecos diverticuli should consist of diverticulectomy with removal of associated bands connecting the diverticulum to the abdominal wall or intestinal mesentery. If the indication for diverticulectomy is bleeding, segmental resection of ileum that includes both the diverticulum and the adjacent ileopeptic ulcer should be performed. Segmental ileoresection may also be necessary if the diverticulum contains a tumor or if the base of the diverticulum is inflamed or perforated. The management of incidentally found asymptomatic Mecos diverticuli is controversial. Until recently, most authors recommended against prophylactic removal of asymptomatic Mecos diverticuli, given the low lifetime incidence of complications. Supporting this approach, a meta-analysis has shown that 758 prophylactic diverticulectomies needed to be performed to prevent one Mecos-related death. 63. Others have had greater enthusiasm for prophylactic diverticulectomy has appeared in the literature. 64. Proponents of this approach cite the minimal morbidity associated with removing Mecos diverticuli and the possibility that previous estimates of the lifetime incidence of complications related to Mecos diverticuli may be erroneously low. Many have advocated a selective approach, with a recommendation to remove diverticuli in patients younger than 50 years of age, or those with band attachments, those with ectopic tissue. Diagnosis was made in this patient using are more likely to develop complications. No controlled data supporting or refuting these recommendations exist. Acquired diverticuli are designated false diverticuli because their walls consist of mucosa and submucosa but lack a complete muscularis. Acquired diverticuli are more common in the duodenum and tend to be located near the ampulla. Such diverticuli are known as periampullary, juxtapapillary, and periviterian diverticuli. Approximately 75% of juxtapapillary diverticuli rise on the medial wall of the duodenum. Acquired diverticuli in the jejunum or ileum are known as jejunarleo diverticuli. 80% of jejunarleo diverticuli are localized to the jejunum, 15% to the ileum, and 5% to both jejunum and ileum. Diverticuli in the jejunum tend to be large and accompanied by multiple other diverticuli, whereas those in the ileum tend to be small and solitary. The prevalence of duodenal diverticuli, as detected on upper GI examinations Fig. 28-29, has been reported to range from 0.16% to 6%, 6.5. Their prevalence, as detected during ERP examinations, has been reported to range from 5% to 27%. 23% prevalence rate has been reported in an autopsy series. The prevalence of duodenal diverticuli increases with age. They are Figure 28-29. Duodenal diverticuli. Clinical presentation: acquired diverticuli are asymptomatic unless associated complications arise. Such complications are estimated to occur in 6% to 10% of patients with acquired diverticuli and include intestinal obstruction, diverticulitis, hemorrhage, perforation, and malabsorption. Periampullary duodenal diverticuli may be associated with cold cholelithiasis, cholangitis, recurrent pancreatitis, and sphincter of Oddi dysfunction. However, a clear link between the presence of the diverticuli and the development of these conditions has not been demonstrated. Symptoms such as intermittent abdominal pain, flatulence, diarrhea, and constipation are reported to be present in 10% to 30% of patients with jejunarleo diverticuli. The relationship between these symptoms and the presence of the diverticuli is similarly unclear. Diagnosis. Most acquired diverticuli are discovered incidentally on radiographic imaging, during endoscopy, or at the time of surgery. On ultrasound and CT scanning, duodenal diverticuli may be mistaken for pancreatic pseudocysts and fluid collections, biliary cysts, and periampullary neoplasms. These lesions can be missed on endoscopy, particularly with forward-viewing endoscopes, and are best diagnosed on upper gastrointestinal radiographs. Enterocolysis is the most sensitive test for detecting jejunal diverticuli. Therapy. Asymptomatic acquired diverticuli should be left alone. Bacterial overgrowth associated with acquired diverticuli is treated with antibiotics. Other complications, such as bleeding and diverticulitis, are treated with segmental intestinal resection for diverticuli located in the jejunum or ileum. Bleeding and obstruction related to lateral duodenal diverticuli are generally treated with diverticulectomy alone. Treatment of such complications in medial duodenal diverticuli that penetrate the substance of the pancreas can be very challenging. Complications related to these medial duodenal diverticuli should be managed non-operatively if possible, using endoscopy. In emergent situations, bleeding related to medial duodenal diverticuli can be controlled using a lateral duodenotomy and oversewing of the bleeding vessel. Similarly, perforation can be managed with wide drainage rather than complex surgery. Whether diverticulectomy should be done in patients with biliary or pancreatic symptoms is controversial and is not routinely recommended. Mesenteric ischemia. Mesenteric ischemia can present as one of two distinct clinical syndromes, acute mesenteric ischemia and chronic mesenteric ischemia. 4 distinct pathophysiologic mechanisms can lead to acute mesenteric ischemia. 1, 2, 3. Arterial embolus. Arterial thrombosis. Vas spasm, also known as non-occlusive mesenteric ischemia or nomi venous thrombosis. 4. Embolus is the most common cause of acute mesenteric ischemia and is responsible for over 50% of cases. The embolic source is usually in the heart, most often the left atrial or ventricular thrombi or valvular lesions. Indeed, up to 95% of patients with acute mesenteric ischemia due to emboli will have a documented history of cardiac disease. Embolism to the superior mesenteric artery accounts for 50% of cases. Most of these emboli become wedged and cause occlusion at branch points in the mid to distal superior mesenteric artery, usually distal to the origin of the middle colic artery. In contrast, acute occlusions due to thrombosis tend to occur in the proximal mesenteric arteries near their origins. Acute thrombosis is usually superimposed on pre-existing atherosclerotic lesions at these sites. Nomi is the result of vas spasm and is usually diagnosed in critically ill patients receiving vasopressor agents. Mesenteric venous thrombosis accounts for 5% to 15% of cases of acute mesenteric ischemia and involves the superior mesenteric vein in 95% of cases. 67. The inferior mesenteric vein is only rarely involved. Mesenteric venous thrombosis is classified as primary if no etiologic factor is identifiable, or as secondary if an etiologic factor, such as heritable or acquired coagulation disorders, is identified. Regardless of the pathophysiologic mechanism, acute mesenteric ischemia can lead to intestinal mucosal sloughing within 3 hours of onset and full-thickness intestinal infarction by 6 hours. In contrast, chronic mesenteric ischemia develops insidiously, allowing for development of collateral circulation, and therefore, rarely leads to intestinal infarction. Chronic mesenteric arterial ischemia results from atherosclerotic lesions in the main splanchnic arteries celiac, superior mesenteric, and inferior mesenteric arteries. In most patients with symptoms attributable to chronic mesenteric ischemia, at least 2 of these arteries are either occluded or severely stenosed. A chronic form of mesenteric venous thrombosis can involve the portal or splenic veins and may lead to portal hypertension, with resulting esophagogastric varices, splenomegaly, and hypersplenism. Severe abdominal pain, out of proportion to the degree of tenderness on examination, is the hallmark of acute mesenteric ischemia, regardless of the pathophysiologic mechanism. The pain is typically perceived to be colicky and most severe in the mid-abdomen. Associated symptoms can include nausea, vomiting, and diarrhea. Physical findings are characteristically absent early in the course of ischemia. With the onset of bowel infarction, abdominal distension, peritonitis, and passage of bloody stools occur. Chronic mesenteric ischemia present. Obscure GI bleeding. Up to 90% of lesions responsible for GI bleeding are within the reach of EGD and colonoscopy. Obscure GI bleeding refers to gastrointestinal bleeding for which no source has been identified by routine endoscopic studies, EGD, and colonoscopy. Overt GI bleeding refers to the presence of hematemesis, melena, or hematochea. In contrast, occult GI bleeding occurs in the absence of overt bleeding and is identified on laboratory tests, for example, iron deficiency anemia or examination of a stool, for example, positive guaiac test. Obscure GI bleeding is occult in 20% of cases. 68. Obscure bleeding can be frustrating for both the patient and the clinician, and this is particularly true for obscure overt bleeding, which cannot be localized despite aggressive diagnostic measures. Most of the small bowel is beyond the reach of these examinations and hence contains most lesions responsible for obscure GI bleeding. Small intestinal angiodysplasias account for approximately 75% of cases in adults, and neoplasms account for approximately 10%. Meckel's diverticulum is the most common etiology of obscure GI bleeding in children. Other etiologies of obscure GI bleeding include Crohn's disease, infectious enteritis, non-steroidal anti-inflammatory drug NSAID-induced ulcers and erosions, vasculitis, ischemia, varices, diverticuli, and intussusception. The diagnostic evaluation of patients with obscure GI bleeding should be tailored to the severity to bleeding and to the availability of technology and expertise. Enteroscopy is playing an increasingly important role. Several endoscopic techniques for visualizing the small intestine are available. Wireless capsule enteroscopy is an excellent tool in the patient who is hemodynamically stable but continues to bleed. This technique has reported success rates as high as 90% in identifying a small bowel pathology. In a randomized study of patients with obscure GI bleeding, evaluation with capsule endoscopy versus small bowel contrast study had a much higher diagnostic yield, 30% versus 7%, respectively. However, this did not translate into an improvement in outcomes. The rates of rebleeding, hospitalization, need for blood transfusion, and therapeutic interventions were similar between the two arms. The inability to perform biopsies or carry out any therapeutic interventions of capsule endoscope likely prevents the improved diagnostic yield of the test from translating into improved patient outcomes and highlights the continuing challenge with evaluation of a small bowel. 69. For patients in whom bleeding from an obscure GI source has apparently stopped, push enteroscopy or capsule enteroscopy is a reasonable initial study. If these examinations do not reveal a potential source of bleeding, then enterocolysis should be performed. Standard small bowel follow-through. To require blood transfusions should then undergo exploratory laparoscopy or laparotomy with intraoperative enteroscopy. An endoscope, usually a colonoscope, is inserted into the small bowel through peroral intubation or through an enterotomy made in the small bowel or cecum. The endoscope is advanced by successively telescoping short segments of intestine onto the end to the instrument. In addition to the endoscopic image, the transilluminated bowel should be examined externally with the operating room lights dimmed, as this maneuver may facilitate the identification of angiodysplasias. Identified lesions should be marked with a suture placed on the serosal surface of the bowel. These lesions can be resected after completion of endoscopy. Examination should be performed during instrument insertion rather than withdrawal because instrument-induced mucosal trauma can be confused with angiodysplasias. Figure 2831 provides a diagnostic and management algorithm for patients with obscure GI bleeding. Small bowel perforation. Prior to the 1980 seconds, duodenal perforation due to peptic ulcer disease was the most common form of small bowel perforation. Today, nitrogenic injury incurred during gastrointestinal endoscopy is the most common cause of small bowel perforation. Other etiologies of small bowel perforation include infections, especially tuberculosis, typhoid, and CMV, Crohn's disease, ischemia, drugs for example, potassium, and NSAID-induced ulcers, radiation-induced injury, Meckel's and acquired diverticuli. Neoplasms, especially lymphoma, adenocarcinoma, and melanoma, and foreign bodies. Among iatrogenic injuries, duodenal perforation during endoscopic retrograde cholangiography ERC with endoscopic sphincterotomy ES is the most common. With improved technique and technology, the incidence of this is decreasing but remains at around 0.5%. 70. The Stafford classification is commonly used to categorize different types of ERC prelated perforations. These are type I, free bowel wall perforation, type Roman II, retroperitoneal duodenal perforation secondary to periampullary injury, type Roman III, perforation of the pancreatic or bile duct, type Roman IV, retroperitoneal air alone. Type Roman II retroperitoneal duodenal injuries are the most common and can often be managed non-surgically. Manifestations of such contained duodenal perforation following ERC can resemble those of ERC-induced pancreatitis, including hyperamylasemia. Examinations are associated with a low diagnostic yield in this setting and should be avoided. 99 MTC. Pertechnetate scintigraphy to diagnose Meckel's diverticulum should be considered, although its yield in patients older than 40 years of age is extremely low. If still no diagnosis has been made, a watch-and-wait approach is reasonable, although angiography should be considered if the episode of bleeding was overt. Angiography can reveal angiodysplasia and vascular tumors in the small intestine even in the absence of ongoing bleeding. In many instances, however, angiography is done in patients with persistent bleeding from an obscure GI source, and it is also often performed after a 99 MTC labeled RBC scan, which, if positive, is followed by angiography to localize the source of bleeding. Patients who remain undiagnosed but continue to bleed and those with recurrent episodic bleeding significant enough, obscure, rule out upper, bleeding, ADA, positive, initiate appropriate, therapy, minor bleeding intermittent, enterocolysis enteroscopy capsule endoscopy, negative, repeat EGD/colonoscopy if, rebleeds, negative, and patient stable. Figure 28. Chylous ascites refers to the accumulation of triglyceride-rich peritoneal fluid with a milky or creamy appearing, caused by the presence of intestinal lymph in the peritoneal cavity. Chylomicrons, produced by the intestine and secreted into lymph. Bleeding, GI, stable, tagged scan, positive, treatment, major bleeding persistent, source uncertain. Localized bleeding, clamping or intraoperative followed by resection, unstable, operating, room, source of bleeding identified. Treat source, for example, small bowel resection. Bleeding, during the absorption of long-chain fatty acids, account for the characteristic appearance and triglyceride content of child. The most common etiologies of chylous ascites in Western countries are abdominal malignancies and cirrhosis. In Eastern and developing countries, infectious etiologies, such as tuberculosis and filariasis, account for most cases. Chylous ascites can also develop as a complication of abdominal and thoracic operations and trauma. Operations particularly associated with this complication include abdominal aortic aneurysm repair, retroperitoneal lymph node dissection, inferior vena cava resection, and liver transplantation. Other etiologies of chylous ascites include congenital lymphatic abnormalities, for example, primary lymphatic hypoplasia, radiation, pancreatitis, and right-sided heart failure. 3 mechanisms have been postulated to cause chylous ascites: exudation of chyle from dilated lymphatics on the wall of the bowel and in the mesentery caused by obstruction of lymphatic vessels at the base of the mesentery or the cisterna chyli, for example, by malignancies, direct leakage of chyle through a lymphoperitoneal fistula, for example, those that develop as a result of trauma or surgery, and C. Exudation of child through the wall of dilated retroperitoneal lymphatic vessels, for example, in congenital lymphangiectasia or thoracic duct obstruction. Patients with childless ascites develop abdominal distension over a period of weeks to months. Postoperative childless ascites can present acutely during the first postoperative week. Delayed presentations following surgery can occur if the mechanism of ascites formation is adhesion-induced lymphatic obstruction rather than lymphatic vessel disruption. Paracentesis is the most important diagnostic test. Child typically has a cloudy and turbid appearance. However, it may be clear in fasting patients, such as those in the immediate postoperative period. Fluid triglyceride concentrations above 110 mg/dl are diagnostic. CT scanning may be useful in identifying pathological intra-abdominal lymph nodes and masses and in identifying extent and localization of fluid. Lymphangiography and lymphoscintigraphy may help localize lymph leaks and obstruction. This information is particularly useful for surgical planning. There is little data on optimal management of patients with childless ascites. The general approach is to focus on evaluating and treating the underlying causes, especially for patients with infectious, inflammatory, or hemodynamic etiologies for this condition. Most patients respond to administration of a high-protein and low-fat diet supplemented with medium-chain triglycerides. This regimen is designed to minimize child production and flow. Medium-chain triglycerides are absorbed by the intestinal epithelium and are transported to liver through the portal vein. They do not contribute to chylomicron formation. Patients who do not respond to this approach should be fasted and placed on TPN. Iodide can further decrease lymph flow. Paracentesis is indicated for respiratory difficulties related to abdominal distension. Overall, 2/3 of patients will respond to conservative therapy. However, 1/3 of patients will require surgical therapy for childless ascites. In general, postoperative and trauma-related cases that fail to respond to initial non-operative therapy are best managed by surgical repair. Lymphatic leaks are localized and repaired with fine non-absorbable sutures. If extravasation of child is localized to the periphery of the small bowel mesentery, then a limited small bowel resection can be performed instead. For patients who are poor surgical candidates and who do not respond to prolonged conservative therapy, peritoneal venous shunting may be an option. However, these shunts are associated with high rates of complications, including sepsis and disseminated intravascular coagulation. Because of the viscosity of child, these shunts are associated with a high occlusion rate. Intussusception refers to a condition where one segment of the intestine becomes drawn into the lumen of the distal segment of the bowel. It is usually seen in the pediatric population, where, a figure 2832, small bowel intussusception, A, target sign B, the distal bowel is clearly within the lumen of the proximal. Finding is of little clinical significance and is probably related to normal peristalsis. In patients who have undergone a Roux-en-Y gastric bypass surgery, an atypical form of intussusception has been increasingly described. In these cases, the distal bowel is drawn into the lumen of the proximal bowel, retrograde intussusception. These intussusceptions are usually not associated with a lead point and may represent a motility disorder of the bowel following the Roux-en-Y reconstruction. Surgical reductions without resection have been successfully reported in these patients. 73. Pneumatosis intestinalis. Pneumatosis intestinalis indicates the presence of gas within the bowel wall. It may affect any region of the GI tract, but it is most commonly seen in the jejunum. Pneumatosis intestinalis is not a disease but merely a sign that can be idiopathic or associated with many intestinal or non-intestinal disorders, such as obstructive pulmonary disease and asthma. Most cases of pneumatosis intestinalis are secondary to an identifiable cause, and 15% are idiopathic. The pathogenesis of pneumatosis intestinalis is not fully understood. The surgical interest in this finding is the association of it with bowel ischemia and infarction, both of which necessitate emergent surgical intervention. Fig. 2833. Thus, patients with this radiological finding need to be fully evaluated and monitored closely to rule out such intra-abdominal catastrophes. The ileum intussuscepts into the cecum ilecolic intussusception. In children, it is often an idiopathic condition and treated non-surgically by radiological reduction. Intussusceptions are far less common and usually have a distinct pathologic lead point, which can be malignant in up to 1/2 of cases. 72. They commonly present with a history of intermittent abdominal pain and signs and symptoms of bowel obstruction. CT scan is the investigation of choice, where a target sign may be seen. Fig. 2832. Treatment is surgical resection of the involved segment and the lead point, which needs to undergo pathological evaluation to rule out an underlying malignancy. With increasing use of CT imaging, target signs are sometimes seen on CT scans of patients who do not have a clinical presentation indicative of bowel obstruction. In such cases, the BCT scans in patients with small bowel intussusception era, short bowel syndrome. Intestinal resection is performed for many of the diseases discussed in this chapter and generally is associated with minimal morbidity. However, when extent of resection is great enough, a devastating condition known as short bowel syndrome may result. Although the best definition of short bowel syndrome is 5, likely a functional one, reflecting a state of significant malabsorption of both macronutrients and micronutrients. Some have used a more anatomical definition, with it being arbitrarily defined as the presence of less than 200 cm of residual small bowel in adult patients. 74. In adults, the most common etiologies of short bowel syndrome are acute mesenteric ischemia, malignancy, and Crohn's disease. 75% of cases result from resection of a large amount of small bowel as single operation. 25% of cases result from the cumulative effects of multiple operations during which small intestine is resected. This latter pattern is typical of patients with Crohn's disease who develop short bowel syndrome. The former is typical of patients with acute mesenteric ischemia who develop intestinal infarction. In pediatric patients, intestinal atresia, volvulus, and necrotizing enterocolitis are the most common etiologies of short bowel syndrome. The prevalence of short bowel syndrome is hard to estimate due to its multifactorial nature and wide spectrum of presentation and treatment, which may include home total parenteral nutrition (TPN). Pathophysiology resection of less than 50% of the small intestine is generally well tolerated. However, clinically significant malabsorption occurs when greater than 50% to 80% of the small intestine has been resected. Among adult patients who lack a functional colon, lifelong TPN dependence is likely to persist if there is less than 100 cm of residual small intestine. Among adult patients who have an intact and functional colon, lifelong TPN dependence is likely to persist if there is less than 60 cm of residual small intestine. Among infants with short bowel syndrome, weaning from TPN dependence has been achieved with as little as 10 cm of residual small intestine. Residual bowel length is not the only factor predictive of achieving independence from TPN enteroautonomy. Figure 2833, step procedure. This illustration depicts the serial transverse enteroplasty step procedure. Lengthening of dilated small intestine is accomplished by serial applications of an intestinal stapling device with firings oriented perpendicular to the long axis of the intestine. Used with permission from Patrick Javid, MD, and Tom Jagzik, MD, Department of Surgery, Children's Hospital, Boston, MA. However, other determinants of the severity of malabsorption include the presence or absence of an intact colon, as indicated previously. The colon has the capacity to absorb large fluid and electrolyte loads. In addition, the colon can play an important, albeit small, role in nutrient assimilation by absorbing short-chain fatty acids. Second, an intact ileocecal valve is believed to be associated with decreased malabsorption. The ileocecal valve delays transit of chyme from the small intestine into the colon, thereby prolonging the contact time between nutrients and the small intestinal absorptive mucosa. Third, healthy, rather than disease, residual small intestine is associated with decreased severity of malabsorption. Fourth, resection of jejunum is better tolerated than resection of ileum, as the capacity for bile salt and vitamin B12 absorption is specific to the ileum, table 2811. During the first 1 to 2 years following massive small bowel resection, the remaining intestine undergoes compensatory adaptation, as discussed previously. Clinically, the period of adaptation is associated with reductions in volume and frequency of bowel movements, increases in the capacity for enteronutrient assimilation, and reductions in TPN requirements. As this process completes, some patients are successfully weaned off TPN. Understanding the mechanisms mediating intestinal adaptation may suggest strategies for enhancing adaptation in patients with short bowel syndrome who are unable to achieve independence from TPN. To date, the phenomenon of intestinal adaptation in patients remains poorly understood. 13. Malabsorption in patients who have undergone massive small bowel resection is exacerbated by a characteristic hypergastroinemia-associated gastric acid hypersecretion that persists for 1 to 2 years postoperatively. Increased acid. Table 2811 risk factors for development of short bowel syndrome after massive small bowel resection. Small bowel length 200 cm, absence of ileocecal valve, absence of colon disease, remaining bowel, for example, Crohn's disease ileoresection. O delivered to the duodenum inhibits absorption by a variety of mechanisms, including the inhibition of digestive enzymes, most of which function optimally under alkaline conditions. Therapy. Medical therapy. For patients after massive small bowel resection, the initial treatment priorities include management of the primary condition precipitating the intestinal resection and the repletion of fluid and electrolytes lost in the severe diarrhea that characteristically occurs. Most patients will require TPN, at least initially. Enteronutrition should be gradually introduced once ileus has resolved. High-dose histamine 2 receptor antagonists or proton pump inhibitors should be administered to reduce gastric acid secretion. Antimotility agents, such as loperamide hydrochloride or diphenoxylate, may be administered to delay small intestinal transit. Octreotide can be administered to reduce the volume of gastrointestinal secretions, although, in animal models, its use is associated with an inhibition of intestinal adaptation. During the period of adaptation, generally lasting 1 to 2 years postoperatively, TPN and enteronutrition are titrated to allow for independence from TPN. Patients who remain dependent on TPN face substantial TPN-associated morbidities including catheter sepsis, venous thrombosis, liver and kidney failure, and osteoporosis. Liver failure is a significant source of morbidity and often leads to liver transplantation, always in combination with small bowel transplantation. Due to these complications, patients with short bowel syndrome on TPN have a reduced life expectancy, with 5-year survival rates of 50% to 75%. Non-transplant surgical therapy. Among patients with stomas, restoration of intestinal continuity should be performed whenever possible, to capitalize on the absorptive capacity of all residual intestine. Other forms of non-transplant surgery designed to improve intestinal absorption are associated with unclear efficacy and / or substantial morbidities and therefore should not be applied routinely. The goal of these operations is to increase nutrient and fluid absorption by either slowing intestinal transit or increasing intestinal length. Operations designed to slow intestinal transit include segmental reversal of the small bowel, interposition of a segment of colon between segments of small bowel, construction of small intestinal valves, and electrical pacing of the small intestine. Reported experience with these procedures is limited to case reports or series of a few cases. Objective evidence of increased absorption is lacking. Further, these procedures are frequently associated with intestinal obstruction. The intestinal lengthening operation for which has the longest history is the longitudinal intestinal lengthening and tailoring Lille procedure. First described by Bianchi in 1980.75, the procedure entails separation of the dual vasculature of the small intestine, followed by longitudinal division of the bowel with subsequent isoperistaltic end-to-end anastomosis. This procedure has the potential to double the length of small intestine to which it is applied. This procedure has generally been used for pediatric patients with dilated residual small bowel. An alternative surgical approach to lengthening the small bowel is the serial transverse enteroplasty procedure step has been described. This procedure is designed to accomplish lengthening of dilated small intestine without the need for separating its dual vasculature. Fig. 2833. A report from an international registry of 111 patients showed that 47% of intestinal failure who have no significant liver disease or failure of other organs. Combined intestine/liver transplantation is used for patients with both intestinal and liver failure. Multivisceral transplantation has been used for patients with giant desmoid tumors involving the vascular supply of the liver and pancreas, as well as that of the intestine, for diffuse gastrointestinal motility disturbances, and for diffuse splanchnic thrombosis. Nearly 80% of survivors have full intestinal graft function with no need for TPN. However, morbidities associated with intestinal transplantation are substantial and include acute and chronic rejection, CMV infection, and post-transplant lymphoproliferative disease. Alternative therapies. Pharmacologic and biologic therapies designed to expand intestinal mucosal surface area or to enhance the efficiency of intestinal absorption are beginning to undergo clinical evaluation. Promising regimens include GLP-2 and the combination of glutamine and growth hormone with a modified, high-carbohydrate diet. Outcomes: approximately 50% to 70% of patients with short bowel syndrome who initially require TPN are ultimately able to achieve independence from TPN. 73. Prognosis for achieving enteral autonomy is better among pediatric patients than among adults. Information on survival among patients with short bowel syndrome is limited. In a recently reported study of 124 adults with short bowel syndrome due to non-malignant etiologies, the survival rates at 2 and 5 years of follow-up were 86% and 45%, respectively. 77. Patients with end enterostomies and those having less than 50 cm of residual small intestine had significantly worse survivals than those without these features. No randomized trials comparing intestinal transplant to chronic TPN administration among patients with short bowel syndrome have been reported. 1, 5, and 10-year graft survival rates of intestine alone recipients were 80%, 44%, and 26%, while those for intestine and liver, and pancreas were 62%, 45%, 36%, and 69%, 48%, 33%, respectively. 78. References. Entries highlighted in bright blue.